Hello my dear friends. Now in this particular sessions we will be discussing the internal medicine, and within this particular subject of internal medicine I will be discussing the endocrinology. So within the endocrinology we will be discussing a very important disorder, that is Pheochromocytoma. First you should know what exactly is the definition of the Pheochromocytoma. So Pheochromocytoma, it is the tumor which is originating from the adrenal medulla. And what does this adrenal medulla secrete? This adrenal medulla, it secretes epinephrine, norepinephrine, and as well as the dopamine. So these are the hormones from the adrenal medulla. And a question that can be asked on this particular topic of Pheochromocytoma is in the following manner. Pheochromocytomas, they arise from non-endocrine cells of adrenal cortex, non-endocrine cells of the adrenal medulla, neuroendocrine cells of adrenal cortex, the neuroendocrine cells of the adrenal medulla. So please remember, the Pheochromocytomas, they originate from the neuroendocrine cells of the adrenal medulla. And these neuroendocrine cells, these are also called as the chromaffin cells in the adrenal medulla. So Pheochromocytoma, it is a tumor which is originating from the chromaffin cells of the adrenal medulla. Now you should know what is the hormone which is predominantly secreted in Pheochromocytoma. So if you see this question over here, Pheochromocytoma predominantly secretes. The options are epinephrine, norepinephrine, dopamine, and as well as the dopa. So you should know the hormones. As already I have said you, the hormones which are being produced by the adrenal medulla are epinephrine and as well as norepinephrine. You take physiologically, right? So in a normal individual, it is your epinephrine which is produced epinephrine is produced in quantities of 80% and norepinephrine is produced in quantities of 20%. So this is in a normal individual, and out of which you take this norepinephrine, it has the shortest T half, right? It has the shortest half-life. But in case of Pheochromocytoma, what is the hormone which is being produced predominantly? In Pheochromocytoma, it is norepinephrine which is produced in excess quantities rather than the epinephrine. And you take this norepinephrine, it is metabolite of the vanillyl manlic acid. Right, it is a metabolite of the VMA. So VMA stands for vanillyl manlic acid. Now apart from this, we also have what is called the extra-adrenal Pheochromocytomas. So adrenal Pheochromocytomas are the tumors which are originating from the neuroendocrine cells of the adrenal medulla or the chromaffin cells of the adrenal medulla. Whereas you take this extra-adrenal Pheochromocytoma. Extra-adrenal Pheochromocytomas, they are called as the paragangliomas. Right, they are called as the paragangliomas. These are your extra-adrenal Pheochromocytomas. Now a question can be asked, what is the predominant hormone which is being produced by the extra-adrenal Pheochromocytomas? Remember, the predominant hormone produced from paragangliomas is also norepinephrine. Right, it is also the norepinephrine. So most extra-adrenal Pheochromocytomas, they secrete norepinephrine. Now what do you understand by this word extra-adrenal Pheochromocytoma? That means we have the same neuroendocrine cells or the chromaffin cells outside the adrenal medulla, and the tumor originates from the cells which are present outside the adrenal medulla, and they are called as the extra-adrenal Pheochromocytomas. Now we have another important terminology called malignant pheochromocytoma. Now, what is malignant pheochromocytoma? In case of the malignant pheochromocytoma, please remember, besides your epinephrine and as well as norepinephrine, the levels of dopamine is very much increased. That is what is called as malignant pheochromocytoma. And this particular dopamine, it is the metabolite of the homovanillinic acid. Now, you should know that these particular hormones, that is epinephrine, norepinephrine and as well as dopamine, they are synthesized from the amino acid tyrosine. So, please remember this very important point. Tyrosine is involved in the synthesis of your epinephrine, norepinephrine and as well as the dopamine. Now, and what did I tell you? In case of the pheochromocytoma, the norepinephrine is the hormone which is produced in predominant quantity. Now, after having discussed about the adrenal pheochromocytoma, you should know what exactly are the sites of the extra-adrenal pheochromocytomas. So, extra-adrenal pheochromocytomas are those like where the chromaffin cells or the neuroendocrine cells are present outside the adrenal medulla, right? So, you see this question, what is the most common extra-adrenal site of the pheochromocytoma? Renal hilum, mediastinum, urinary bladder, the organ of Zucker candle. I'll tell you the answer and later on I'll just tell you what are all the common extra-adrenal sites for the pheochromocytoma. The most common site is the organ of Zucker candle. Now, what is this particular organ of Zucker candle? Organ of Zucker candle, it is the chromaffin body which is present in the abdominal para-aortic area. So, in the abdominal para-aortic area, your organ of Zucker candle, it is a chromaffin body. Right, so that is what is the organ of Zucker candle. And please remember another name which is given to this particular paragangliomas, they are chemodectomas, right? So this paragangliomas, so extra-adrenal pheochromocytomas, like what did we discuss? They are called paragangliomas. And these paragangliomas, right, they are the extra-adrenal tumors which are also given the name that is chemodectoma. So this particular paragangliomas, they predominantly secrete norepinephrine and they also produce even dopamine as well. And these paragangliomas, which are extra-adrenal tumors, they are either sympathetic or parasympathetic origin. So they originate from sympathetic ganglionic cells or vagal ganglion cells. Right, sympathetic or the vagal ganglion cells. Now, these paragangliomas, they also originate from or they arise from the carotid body. Right, they also arise from the carotid body. So that is why it is called carotid body tumor, and the size of the carotid body tumor is equal to a size of a potato. So that is the reason why these are also called as the potato tumors. Right, that is the reason why these are also called as the potato tumors. Right, so that is about the story of your paragangliomas. Now let me tell you what are the locations of this particular paragangliomas. These are extra-adrenal pheochromocytomas, but what are the locations? Let me tell you. So if you take the location of this paraganglioma, the most common site already we have discussed, that is abdominal para-aortic area, which is nothing but the organ of Zucker candle. Now, apart from this organ of Zucker candle, the other important sites where you have this paragangliomas is they are also present in the urinary bladder, and next to this particular urinary bladder, the other common sites are thorax, head and neck, and they are also present in the pelvis. Right, but majority of it, like what is the percentage? Nearly around 75% of the extra-adrenal pheochromocytomas, they are present in the abdominal para-aortic area, which is nothing but the organ of Zucker candle. Right? Now, after having discussed about your adrenal pheochromocytoma, extra-adrenal pheochromocytoma, which is also called paragangliomas, now let me go on to the discussion of the clinical features of the pheochromocytoma. Right. So regarding the clinical features, you can have a question like this. All are the clinical features of pheochromocytoma except increased hematocrit, orthostatic hypotension, low cortisol levels, impaired glucose tolerance. So the clinical features I'll explain you, but this is how the question can be asked. But please remember, the clinical feature which is not present, the question asked is except. The one which is not present in pheochromocytoma is your low cortisol levels. Whereas in pheochromocytoma, you can have the remaining all. There can be increased hematocrit, there can be orthostatic hypotension, and there can be also the impaired glucose tolerance. Now, coming to your low cortisol levels. Low cortisol levels is seen in individuals with the Addison's disease. So in Addison's, there will be low cortisol and there will be also low aldosterone. Right? And there will be also reduced weak sex hormones. Right? So that is about like what you will have in the Addison's disease. But low cortisol is not the feature of your pheochromocytoma. Now, let me discuss the clinical features in pheochromocytoma in a system-wise manner. First, you take the cardiovascular manifestations in patients with the pheochromocytoma. So first of all, you should know the basic physiology, then you will understand what are the clinical features in pheochromocytoma. Please remember, in pheochromocytoma, you have increased epinephrine and as well as norepinephrine. So what will be the effect of this increased epinephrine and norepinephrine over the heart? There will be increased heart rate, right? That is positive chronotropic effect. There will be increased force of contraction, that is nothing but positive inotropic, and there will be increased velocity of the conduction, that is nothing but positive dromotropic effect, and there will be also increased excitability, that is nothing but your positive bathmotropic effect. That is what is the basic physiology of your epinephrine and norepinephrine on the heart. And apart from that, this epinephrine and norepinephrine, what it will do on the blood vessels? It will cause vasoconstriction. That is what is the physiological action of epinephrine and norepinephrine on the blood vessels. So on the blood vessels, you have alpha-1 receptors. On this particular alpha-1 receptors, this epinephrine and norepinephrine will come and act and they will cause the vasoconstriction. So now please remember what will happen, right? Please remember what will happen. When there is increased epinephrine and norepinephrine, there will be excessive vasoconstriction and that will make the individual to land up in the hypertension. So please remember, in patients with the pheochromocytoma, the most common manifestation is the hypertension, right? The most common manifestation is the hypertension. Now, this particular hypertension, it can be paroxysmal hypertension and sustained hypertension. So what do you understand by the word paroxysmal hypertension? Paroxysmal hypertension is there will be sudden onset increase in the blood pressure. And why is that? That is because in pheochromocytoma, you have pulsatile release of epinephrine and norepinephrine. Right? You have pulsatile release of epinephrine and norepinephrine in excess quantity in pheochromocytoma. and that is the reason why there will be paroxysmal hypertension. And this paroxysmal hypertension is seen in almost 40% of individuals, and sustained hypertension is present in almost 60% of individuals, right? So, and because of the hypertension, what will be the clinical manifestation? The clinical manifestation will be in the form of the headache. Right, the clinical manifestation will be in the form of headache. So that is the most common manifestation of the pheochromocytoma, right? Now, after having discussed about the hypertension part in pheochromocytoma, what will be the effect on the cardiovascular system, that is on heart rate, force of contraction, velocity, excitability in pheochromocytoma? Let me discuss that. So the basic physiology I have already taught you. So because of this positive chronotropic effect, there will be excessive increase in the heart rate of the individual, that will make the individual to develop tachycardia. And because of this particular tachycardia, the individual will develop palpitations, right? And then I said you that there is increased velocity of the conduction and as well as the excitability as well. So because of that, the individual who is in a state of tachycardia will go on to a state of the arrhythmias. Right, will go into a state of the arrhythmias. So arrhythmias are very common in patients with your pheochromocytoma. Right, arrhythmias are very common in patients with your pheochromocytoma because of increased heart rate, because of increased excitability, because of increased velocity of the conduction. And all the types of arrhythmias can be seen: ventricular tachycardia, ventricular fibrillation, atrial fibrillation. All the forms of the arrhythmias can be seen in patients with your pheochromocytoma. Right. After having discussed about this, the another important point you should know is that in pheochromocytoma there is increased myocardial excitability. Right, there is increased myocardial excitability, and that is the reason why the individual is landing up in arrhythmias. But at the same time, what you should know is, when the heart is in the state of the arrhythmia, what will happen to your myocardial oxygen demand? The myocardial oxygen demand increases. Right? The myocardial oxygen demand increases. Okay. But what is happening on to the contrary? There is increased myocardial oxygen demand, but there is very severe coronary vasospasm. Why there is very severe coronary vasospasm? Because your increased epinephrine and norepinephrine in pheochromocytoma, they will go and act on the alpha-1 receptors which are present on the coronary arteries, and they will cause very severe coronary vasospasm. So on one side there is increased myocardial oxygen demand, right? On other side there is coronary vasospasm. So thereby what will happen to your myocardial blood supply? The myocardial blood supply will be decreased. So there is increased oxygen demand and there is decreased supply. Right? There is decreased supply. And this will make the individual to land up in angina, and subsequently the individual can progress to develop myocardial infarction. Right? Subsequently the individual will progress to develop myocardial infarction. So that is what you will see in patients with your pheochromocytoma. Next, coming to the increased metabolic rate. Please remember, what is the basic physiology of epinephrine and norepinephrine on the basal metabolic rate of the individual is epinephrine and norepinephrine, it increases the basal metabolic rate. So in case of pheochromocytoma, what will happen when there is increased epinephrine and as well as norepinephrine? There will be excessive increase in your basal metabolic rate. Right, there will be excessive increase in the basal metabolic rate. So because of excessive increase in the basal metabolic rate, the individual will have profuse sweating. Right, and apart from that, there will be weight loss. That is another important feature of the excessive metabolic rate. Okay, and then increased body temperature. So these are the features like what you will have because of increase in the metabolic rate of the individual in patients with the pheochromocytoma. Next, having discussed about the cardiovascular manifestation and as well as the basal metabolic rate, let me tell you what will happen in patients with pheochromocytoma on the carbohydrate metabolism. So again in this, you should know what does your epinephrine and as well as norepinephrine does on the carbohydrate metabolism. Please remember, epinephrine and as well as norepinephrine, they have anti-insulin action. So it will reduce the activity of the insulin. And not only that, the epinephrine and norepinephrine will also increase this epinephrine and norepinephrine will also increase glycogenolysis, right? Will also increase the glycogenolysis. So glycogenolysis is like where the glycogen is broken into the glucose. That is called glycogenolysis. So because of this anti-insulin action and because of increased glycogenolysis caused by your epinephrine and norepinephrine, in pheochromocytoma what will happen is in pheochromocytoma there is increased epinephrine and as well as norepinephrine. So that physiological actions whatever have been done by the epinephrine and norepinephrine, they get exaggerated and thereby there will be hyperglycemia. Right, and due to which the individual will have impaired carbohydrate tolerance. Right, so due to which they have the impaired carbohydrate tolerance, so they'll have hyperglycemia. So that is what you will see in patients with the pheochromocytoma. Now, apart from this, you should know what are the other manifestations in pheochromocytoma. In pheochromocytoma, there is very severe vasoconstriction. So, because of very severe vasoconstriction, there will be decrease in the plasma volume. And because of decrease in the plasma volume, there will be elevated hematocrit. Right, there will be elevated hematocrit. So, in patients with pheochromocytoma, please remember there is increase in the hematocrit within the individual. Now, apart from that, in patients with pheochromocytoma, there will be also blunting of the sympathetic reflexes. Now, why is that? You take sympathetic nervous system, it will produce epinephrine and as well as norepinephrine, right? The neurotransmitter of sympathetic nerve terminals is your epinephrine and as well as norepinephrine. And in pheochromocytoma, there is also excessive production of your epinephrine and as well as norepinephrine. So, the epinephrine and norepinephrine, whichever is being produced by your pheochromocytoma, it will suppress the activity of your epinephrine and norepinephrine, which is being produced by your sympathetic nervous system. And remember, the very important role of the sympathetic nervous system is in the maintenance of the orthostatic blood pressure. So, whenever we stand from supine position, so if you see here, from the supine position, whenever we stand, the blood pressure of the individual drops down because of decrease in the venous return and because of the gravity pull. So, this fall in the blood pressure is immediately corrected by the sympathetic nervous system of our body. But what is happening in your pheochromocytoma? In pheochromocytoma, the sympathetic reflexes, they are blunted. There is blunting of the sympathetic reflexes. Now, because of blunting of the sympathetic reflexes, the individual will land up in what is called orthostatic hypotension. Right, will land up in what is called orthostatic hypotension. So, orthostatic hypotension is that the individual from supine position, whenever he stands, right, whenever he stands, the blood pressure, it falls down. And what is the fall in the blood pressure whenever he stands? If the blood pressure falls more than 20 millimeters of mercury, systolic blood pressure, more than 10 millimeters of mercury, diastolic blood pressure, if it is a fall, that is when we use the word orthostatic hypotension. And when should these be measured? Not immediately whenever the individual stands. So from supine position to the standing position, after 1 to 3 minutes, if you check the blood pressure and if you measure the blood pressure and if the fall in the blood pressure, systolic blood pressure is more than 20 millimeters of mercury and fall in the diastolic blood pressure is more than 10 millimeters of mercury, that is the point when we use the word orthostatic hypotension. Right, that is the point when we use the word orthostatic hypotension, and orthostatic hypotension is one of the features like what you will have in patients with the pheochromocytoma. Now, in pheochromocytoma, there is ectopic secretion of the parathormone. Right, from the pheochromocytoma itself, there is ectopic secretion of parathormone. What does the parathormone does? Parathormone related proteins are secreted from the pheochromocytoma, and that will cause increase in the calcium levels. So the individual will end up in what is called hypercalcemia. So what is the normal calcium levels? Normal calcium levels are 9 to 11 milligrams per deciliter. So here there will be hypercalcemia. And please remember, whenever there is hypercalcemia, what will be the drug of choice? The drug of choice in patients with your hypercalcemia is, again it depends upon the level of increase in your calcium levels. Okay, so if the calcium levels are like in between 11 to 12 or 11 to 13, we initially start with the normal saline, and along with that we start furosemide. Right, along with that we start furosemide. So that will start flushing out the calcium. Right, that will start flushing out the calcium. Okay, right. Now, after having discussed about the cardiovascular manifestations, basal metabolic rate, orthostatic hypotension, action on the carbohydrates, hypercalcemia, let me discuss what exactly is the classical triad of symptoms in pheochromocytoma. The classical triad of symptoms in pheochromocytoma includes episodic headache. So this episodic headache, this is due to hypertension. Now, why am I telling the word episodic? Because in these individuals with pheochromocytoma, there is pulsatile release of your epinephrine and norepinephrine. So, because of pulsatile release of your epinephrine and norepinephrine, the individual will be having the episodic headache. Now, apart from that, please remember, in pheochromocytoma, they will also have the other important feature, that is tachycardia. So because of this tachycardia, the individual can have palpitations. Right? The individual will have the palpitations. And then there will be also profuse sweating. So why is this particular profuse sweating within the individual? That is because of increase in the basal metabolic rate. Right? That is because of increase in the basal metabolic rate. So out of all these triad, what is the most common sign and symptom of pheochromocytoma? The most common sign in pheochromocytoma is your hypertension. And secondary to hypertension, the individual will have the headache. Right? Secondary to hypertension, the individual will have the headache. Now, you should know a rule of 10 in pheochromocytoma. This particular rule of 10 is not being followed nowadays, but for an academic interest, let me tell you what is this particular rule of 10. 10% of these tumors, they are the extra-adrenal. Right? And 10% of the tumors, they are present bilaterally. 10% of the tumors, they are seen in children, and 10% of the tumors, right, they are familial, and 10% of the tumors, they are malignant. So this is what is called as the rule of 10, right? So not being followed nowadays very classically, but this will be for you for an academic interest, that is rule of 10. Now, in pheochromocytoma, what is happening? There is excessive alpha activity and there is also excessive beta activity as well, because your epinephrine and norepinephrine will go and act on alpha receptors and as well as the beta receptors. So there is excessive alpha and beta adrenergic stimulation of the cardiovascular system, and that will produce 5 P's of the paroxysm. So what is that 5 P's that you should remember? Paroxysmal hypertension, then the individual will have pounding headache because of this paroxysmal hypertension, and they can also have perspiration. So perspiration in the sense like profuse sweating, then palpitations, right, that is tachycardia, and they will be also pallor, right, that is because of very severe vasoconstriction, right. So these are the 5 P's of your pheochromocytoma. Now, after having discussed about this, going back to the question like what we were discussing initially for the clinical features, all are the clinical features of pheochromocytoma except increased hematocrit will be there, that is because of very severe vasoconstriction and due to decrease in the plasma volume. Orthostatic hypotension will be there, that is due to blunting of the sympathetic reflexes, and impaired glucose tolerance will be there because of the anti-insulin action and as well as increased glycogenolysis. But low cortisol is the feature of your Addison's disease, but that is not the feature of your pheochromocytoma. So next, let me discuss the investigations in pheochromocytoma. So the question can be asked as the investigation of choice in pheochromocytoma is CT scan, the urinary catecholamine levels, MIBG scan, urinary calcium measurement. So the answer to this particular question is the urinary catecholamine levels. Please remember, it is the 24-hour urinary catecholamine levels which will be elevated. Right, so that is what you will see in patients with the pheochromocytoma. And apart from this 24-hour urinary catecholamine levels, we should also do the imaging studies. But let me first discuss about the urinary catecholamine levels. Normally, these catecholamines are metabolized within the chromaffin cells to metanephrines, right? And what exactly we check within the urine is your metanephrines. Metanephrines is the one like what we test in the urine or the plasma. So 24-hour urinary metanephrine levels will be elevated. And what is the very important metanephrine? That is your VMA. VMA stands for vanillin malic acid. Right, VMA stands for vanillin malic acid. And what is the normal VMA levels? The normal VMA levels will be less than or equal to 6 milligrams per 24 hours. That is the normal VMA levels. And what is the investigation of choice? The investigation of choice for screening is 24-hour urinary fractionated metanephrine levels that will be elevated. So mainly we need to test within the urine rather than the plasma. And why is that? Because of the sensitivity and as well as the specificity compared to your metanephrines and as well as the catecholamines. We don't test for the catecholamines, we test rather the 24-hour urinary metanephrines. So, if you take the sensitivity and as well as specificity, the rise in metanephrines is almost 98% sensitive and 92% specific in pheochromocytoma. But the same patients with pheochromocytoma, the rise in catecholamine levels is only 85% sensitive and 86% specific. So this is a very, very important point that you should remember, that we need to test for 24-hour urinary metanephrines, not the catecholamines. And what should be that level of the metanephrines that should be elevated? Please remember, the level of the metanephrines that should be elevated is more than fourfold the upper limit. Right? The level of the metanephrine that should be elevated is more than fourfold the upper limit. That is highly diagnostic of your pheochromocytoma. But for suppose, if that level of the metanephrines whichever are elevated is less than fourfold, they should undergo clonidine suppression test. Now, what is this particular clonidine suppression test and why do we do this clonidine suppression test? Let me explain you. So, whenever the increase in your epinephrine and norepinephrine is more than fourfold, definitely it is confirming the diagnosis of your pheochromocytoma. There is no doubt in that. But if the level, if it is less than fourfold, then it is doubtful. Why? Because that increase in your epinephrine and as well as norepinephrine, right? This increase in your epinephrine and norepinephrine, this could be due to increase in the sympathetic activity as well. So because of increase in the sympathetic activity also, there can be rise in your metanephrines. But due to increase in sympathetic activity, the rise in your epinephrine and norepinephrine will be less than fourfold, but not more than fourfold. But in pheochromocytoma, there can be increase in your epinephrine and norepinephrine less than fourfold as well. Then how will you differentiate? So, in order to differentiate that rise in your epinephrine and norepinephrine is because of sympathetic activity or because of your pheochromocytoma, we need to do this clonidine suppression test. And what is the dose of the clonidine what we give in case of the clonidine suppression test? You see this question, dose of clonidine in suppression test done for pheochromocytoma is 0.3 milligrams, 10 milligrams, 100 milligrams, 200 milligrams. So the dose of clonidine in suppression test done for pheochromocytoma is 0.3 milligrams, right? It is 0.3 milligrams. Now, what is this particular clonidine? Clonidine, remember, it is centrally acting alpha-2 adrenergic receptor agonist, right? It is centrally acting alpha-2 adrenergic receptor agonist. So that is what is the clonidine. And this clonidine, which is centrally acting alpha-2 adrenergic receptor agonist, that will normally suppress the release of catecholamines from the neurons. But this particular clonidine does not affect the catecholamine secretion from the pheochromocytoma. So whenever you give clonidine, this clonidine can suppress the epinephrine and norepinephrine which is coming from the sympathetic nervous system. But it cannot suppress the epinephrine and norepinephrine coming from your pheochromocytoma. So, by using this particular clonidine suppression test, we can differentiate whether the patient is having pheochromocytoma or whether the patient is having increased sympathetic activity. But for suppose, if that increase in your epinephrine and norepinephrine is, if it is like more than fourfold, you don't require to do this clonidine suppression test. It's a confirmed case of pheochromocytoma. But if that increase in your epinephrine and norepinephrine is less than 4-fold, that is the point when you need to do this clonidine suppression test, right, to differentiate the pheochromocytoma and increase its sympathetic activity. Now, so always remember in your endocrinology, it is the chemical analysis first, and then followed by that, you will do the imaging studies for the tumor localization. Now, what are the imaging studies like what we do for the tumor localization? CT or the MRI of the abdomen. So, this particular CT or MRI of the abdomen, please remember, they have excellent or a very good sensitivity. But the problem with the limitation with your CT or MRI is they lack specificity. Mainly when the tumor size is less than 1.5 centimeters, they lack specificity. Now, what is the imaging study which will increase the sensitivity and as well as specificity? You take iodine 123 MIBG scan, that is meta-iodo-benzyl guanidine scan, right? That is meta-iodo-benzyl guanidine scan. So, iodine 123 MIBG scan, it has good sensitivity and specificity. Right? So, that is about your iodine 123 MIBG scan. Okay. Now, in order to diagnose the extra-adrenal pheochromocytomas, which are nothing but the malignant tumors, the imaging study like what we do is FDG PET scan. So, what is this FDG PET scan stands for? FDG, it stands for what is called fluorodeoxyglucose positron emission tomography. So, this FDG PET scan, this is mainly for malignant tumors. Right, this is mainly for the malignant tumors, right, which are nothing but your extra-adrenal pheochromocytomas. So, this is your imaging studies for the tumor localization. CT or MRI, right, they have good sensitivity but poor specificity, it lacks specificity. And iodine 123 MIBG scan, that is meta-iodo-benzyl guanidine scan, it has a very good sensitivity and specificity. And for localization of the extra-adrenal pheochromocytomas, we do the fluorodeoxyglucose positron emission tomography. Now, after having discussed about the investigations, let me discuss the treatment. So, but before that, you see this question, all of the following are increased in pheochromocytoma except vanillyl mannalic acid, metanephrines, 5-hydroxyindolestric acid, catecholamines. So, please remember, in pheochromocytoma, there will not be increase in your 5-hydroxyindolestric acid. So, this 5-hydroxyindolestric acid, it is increased in patients with the carcinoid syndrome. So, in carcinoid syndrome, you have increase in the serotonin or your 5-hydroxyindolestric acid. And in carcinoid syndrome, it is mainly the right-sided heart is most commonly affected. That is mainly the valves which are present on the right side of the heart. So, the individual can develop tricuspid regurgitation and as well as pulmonary stenosis. That is what is the cardiac manifestations in the carcinoid syndrome. Now, let me move on to the discussion of the treatment. But before going on to the treatment, you see some more questions. All of the following are the features of the pheochromocytoma except hypertensive paroxysms, headache, orthostatic hypotension, wheezing. Please remember, wheezing is not the feature of the pheochromocytoma. The remaining all can be seen in patients with the pheochromocytoma, right? And you see the next question. Most common symptom of pheochromocytoma is the headache, palpitations, abdominal pain and hypotension. So, we have discussed the same point that headache is the most common symptom of your pheochromocytoma. Now, coming to the treatment in patients with the pheochromocytoma, please remember, complete tumor removal is the ultimate therapeutic goal, right? So the treatment of choice is complete tumor removal. Right? So that is the surgical treatment in these patients. That is the treatment of choice. But always remember, preoperative patient preparation is very much essential for safe surgery. Because in patients with pheochromocytoma, they have the very high blood pressures. So you need to control the blood pressure within these individuals. And you have to control the blood pressures with alpha-adrenergic blockers. And these alpha-adrenergic blockers, the example includes phenoxybenzamine. Right, phenoxybenzamine, which is an alpha blocker. And this phenoxybenzamine, it should be initiated at relatively low doses. Right, and what is that particular low dose of the phenoxybenzamine is? That will be around 5 to 10 milligrams orally, thrice daily. So that will be the dosage of your phenoxybenzamine, and the dose should be increased as tolerated every few days. Okay, right. So phenoxybenzamine is the drug of choice for control of the hypertension in patients with your hypertension in pheochromocytoma. And what should be the target blood pressure preoperatively? The target blood pressure should be less than 160 by 90 millimeters of mercury. Right, less than 160 by 90 millimeters of mercury. And the dosage of your phenoxybenzamine can be increased to a dosage of 20 to 30 milligrams. Right, it can be increased to 20 to 30 milligrams thrice daily per day. Now, apart from that, the other antihypertensives that can be used is the prazosin. So, prazosin or intravenous phentolamine that can be used to manage the paroxysms while awaiting for the adequate alpha blockade. So, the other antihypertensives that can be given is oral prazosin and as well as the intravenous phentolamine. So please remember these particular drugs, right? They are used to manage the paroxysms while awaiting for the adequate alpha blockade. And for suppose if the individual has the intraoperative paroxysms, if the individual has the intraoperative paroxysms, you need to give intravenous phentolamine drip. Right, you need to give the intravenous phentolamine drip if there is intraoperative paroxysms. For suppose if the individual is having intraoperative hypertensive crisis, so when the individual has intraoperative hypertensive crisis, the drug of choice will be intravenous nitroglycerin drip. Right, intravenous nitroglycerin drip. And as I have said you, before surgery, the blood pressure should be consistently below 160 by 90 millimeters of mercury. Now, coming to your beta blockers. Please remember this very important point about the beta blockers. Beta blockers, you can give propranolol, right? And how much amount of the propranolol you should give is 10 milligrams. This 10 milligrams should be given 3 to 4 times per day. But the point you should know is that these beta blockers can be added after starting the alpha blockers, and the dosage of the beta blockers should be increased as the need in the patient. And this particular propranolol should never be given before the alpha blockers. First alpha blockers, then beta blockers. And why is that? Why? Because if you give the beta blockers first, there will be unopposed alpha action, right? There will be unopposed alpha action. Okay, so this epinephrine and norepinephrine, instead of going and acting on the beta receptors, because your beta receptors are blocked by the beta blocker you are giving initially, and that increased epinephrine and norepinephrine will go and act on alpha receptors, that will lead to unopposed alpha action, and that will make the individual to land up in hypertensive crisis. So this should never be done. First alpha blockers and then the beta blockers should be given. Then followed by that, for suppose if the surgery is contraindicated, right? If surgery is contraindicated, like for example, you take in case of malignant pheochromocytoma. So in case of malignant pheochromocytoma, what is that we have discussed? It is like extra-adrenal pheochromocytomas. So in case of malignant pheochromocytoma, you cannot do surgery. So you have to give met-tyrosine. So please remember this met-tyrosine, it inhibits the catecholamine production. Right? It inhibits the catecholamine production. And the other antihypertensives that can be given in patients with the pheochromocytoma is, you can give labetalol. Labetalol, it is both alpha plus beta blocker. Right? It is both alpha plus beta blocker. So that is what is your labetalol. And please remember, labetalol can be given in the place of your beta blockers, that is propranolol, to control the heart rate of the individual. Now, so this is the treatment. So the treatment of choice is surgical resection of the tumor. And in a scenario where the surgery cannot be done, you need to give met-tyrosine. But before the surgery, the blood pressure should be less than 160/90. And for that, you need to do an adequate preoperative preparation with the help of the phenoxybenzamine and the other drugs like phentolamine and as well as prazosin. Okay. Now, you see some of the multiple choice questions on the same topic of pheochromocytoma. Vanillin malic acid levels is elevated in which of the following conditions? Primary micronodular adrenal hyperplasia, Conn syndrome, neuroblastoma, tuberous sclerosis. Please remember the clinical scenario where the vanillin malic acid levels are elevated is the neuroblastoma. So vanillin malic acid, it is a metabolic byproduct of the norepinephrine and as well as epinephrine, and it is used for the detection of neural crest origin, right? It is used for the detection of tumors of the neural crest origin. Now, in what all tumors you have this increase in the vanillin malic acid levels? So please remember, in neuroblastoma, pheochromocytoma, ganglioblastoma, ganglioneuroma, and as well as severe anxiety. In all these clinical conditions, there can be increase in your vanillin malic acid levels, and that is the reason why vanillin malic acid levels being elevated is not considered as the investigation of choice. That is considered as an initial screening test in pheochromocytoma. And once your vanillin malic acid levels are elevated, then you need to do the imaging studies in order to localize the tumor, right? Next, you see another question. Which of the following is true about the pheochromocytoma? Sesame B scan is done before surgery, mostly or malignant. Surgery is the mainstay of treatment. Prior alpha blockade is given, prior beta blockade is given. So in this question, we have two answers. Number one, surgery is the mainstay of treatment. And second important point, the prior alpha blockade is very much required before giving your beta blockade, right? So this is what is the true statement. And what about this Sesame B scan? It is not mandatory to be done before surgery, right? CT or MRI, it has a very good sensitivity and that can pick up where exactly is the location of the tumor, right? And in order to improve the sensitivity and specificity, we have meta-ido benzyl guanidine scan, that is MIBG scan. And mostly or malignant is wrong statement. Only 10% of the tumors, they are malignant. And you should never give a prior beta blockade. And what is the reason? As already I have said you in the treatment part as well. Now, last question. Drug for management of hypertension in pheochromocytoma. Phenoxybenzamine, phentolamine, levotalol, esmolol. Please remember, phenoxybenzamine has to be given. And this phenoxybenzamine should be given at a dosage of 5 to 10 milligrams thrice daily. And this has to be increased to a dosage of 20 to 30 milligrams. That is a maximum dose, and this will help in controlling the blood pressure to less than 160 by 90 millimeters of mercury before surgery, right? So these are some of the very important points related to your pheochromocytoma and their respective multiple choice questions. And one important last question is, in case of pheochromocytoma, the diagnostic test that should be avoided: MRI scan, urinary metanephrines, MIBG scan, FNAC. FNAC should be avoided. Now, why is this particular FNAC should be avoided? See, this is a simple logical question. See, when you are putting a needle in a tumor which is deep inside the medulla, whenever you are trying to put the needle and try to aspirate the medullary contents, there is a high chance that the medulla can release the catecholamines, which is like a volcano waiting to explode. So please remember, FNAC should never be done in patients with your pheochromocytoma. That is a very important point related to your pheochromocytoma. So with this, I wind up this session, and in the next upcoming sessions, we will discuss the remaining topics related to your endocrinology. Thank you very much.